Two of the most common types of injuries are upper brachial plexus injury and lower brachial plexus injury. Upper lesions of brachial plexus are injuries resulting from excessive displacement of head to the opposite side and depression of the shoulder on the same side, that causes excessive traction or even tearing of C5 and 6 roots of plexus, such as might occur during a fall from a motorcycle. These deficits is known as Duchenne palsy. Muscles that will consequently be affected are supraspinatus and infraspinatus, subclavius, coracobrachialis, biceps brachii, brachialis, deltoid and teres minor. The position of the upper limb in this condition has been likened to that of a porter, or waiter hinting for a tip, thus is referred to as waiter's tip posture. Lower lesions of brachial plexus are usually traction injuries caused by excessive abduction of the arm, as in the case of person falling from a height clutching at an object to save himself. Damage to these structures compromises muscles in the forearm and hand, resulting in Klumpke's palsy. This paralysis is typified by claw hand in which the fingers are flexed. Now, we will discuss clinical signs associated with injury to some of the individual nerves of the brachial plexus. Most nerves have both sensory and motor components that can be clinically assessed. Note that sensory signs of nerve injury include loss of sensation, as well as paresthesia, which is a tingling, burning or pins and needles sensation. We will discuss only the nerves that are frequently injured, and that present distinctive clinical signs. These are the long thoracic nerve, and the 5 terminal branches of the brachial plexus: axillary nerve, radial nerve, musculocutaneous nerve, ulnar nerve, and median nerve. Long thoracic nerve injury can result from blows or pressure on the posterior triangle of the neck or trauma to the upper lateral chest wall. The long thoracic nerve travels inferiorly on the lateral chest wall to supply motor innervation to the serratus anterior muscle. Paralysis of serratus anterior can happen, causing difficulty in raising the arm above the head. The scapula will no longer be closely applied to the chest wall, and will protrude posteriorly in a condition known as winged scapula. And this is typically tested by asking the patient to support his weight with his hands while leaning against a wall. The axillary nerve is the terminal branch of the posterior cord, and travels posteriorly through the quadrangular space to innervate the deltoid and teres minor muscles. The axillary nerve is particularly susceptible to injury during fracture of the surgical neck of the humerus. Retraction injury to the axillary nerve may occur during shoulder dislocation. Axillary nerve injury results in the loss of shoulder abduction due to paralysis of the deltoid muscle. In addition, paralysis of the teres minor muscle results in weakened external rotation of the humerus at the shoulder, since teres minor contributes to the rotator cuff.